Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Hello and welcome to the Dr. Journal Club podcast. We are on a short schedule today, so there will be very little chit-chat. We are going to jump right into the paper, or close there too. Adam, how you doing, sir? Just quick chit-chat, super fast.
I'm great. I am very much prepared for this paper.
That is not true. I happen to know. Adam was pulling it up on his computer screen not 30 seconds ago. So we will be gentle on him. But I think it's a pretty straightforward paper. And also, I kind of like when we've done a couple of these where we've done them off the cuff. And I kind of feel like it models what we look for, to the audience. So that's good. I like it. Okay. But I'm prepared, so at least one of us is prepared. So I think we'll be all right. So I'll just, have to carry the podcast today. Whatever. What else is new?
As per usual.
Yeah. All right. So this paper today, which Michelle, I will send you the link this time. And here is the challenge, Josh. Can I get it to her before she's like, Josh, we need to publish. Can you send it to me too? So I'm going to get it to you today. This was sent by a patient who has some, young kids, and as I can attest, because we just went through this season, little kids like to get strep throat, and they like to get it again and again and again, and they like to give it to everyone in the family, and then everyone has to stay home from work and home from school, and then you have to get rid of the toothbrushes, and then did I miss a day? Do we need to get new toothbrushes, replace it again? So gone through all of this, so I totally get it. And she was like, hey, what about probiotics to prevent this? And I was like, oh, that's interesting. I'm kind of curious. Do you know, have you seen anything? And she sent me a couple articles. I have the best patients, by the way. They send me articles. And this one looked interesting on its title. And I was like, yeah, cool. We'll do it on the podcast because I'm curious myself and for clinic. Not that I do a lot of peds. And we'll talk about it. So that's how we got this paper today. That's our preamble, and also me stalling for Adam to read through.
I'm supposed to be reading? I was waiting for you to shut up.
Yeah. Oh, man. You guys, you're in a treat. You're in for a treat today, dear listener. All right. So, Adam, where should we jump in? And so, all joking aside, not giving you a hard time, I really do think that modeling how we freshly look at papers is useful to the audience. So let's go through that. We've done this once or twice before. What's the first thing you walk me through your thoughts as you look at it with fresh eyes, and then I can weigh in if there's anything I saw different.
Well, this is strep throat. Specifically, this is actually streptococcal viral pharyngotonsillitis in children. So we don't need to read the introduction because it's a pretty common occurrence. So let's save some time and just skip the introduction and basically just jump straight to the methods.
Okay, hold on. Before you do that, I know you don't like the intro. I sometimes do. There's a few interesting things that I saw. One is this phrase, lantibiotics. Look at that. Second line of the introduction. Have you ever seen that before?
I have not.
I'm like, am I just a total idiot and missed that day in naturopathic medical school? I have never seen that.
It's possible.
Yeah. But I was like, first I thought it was a typo. I was like, did they put a 1 in front of antibiotics and it didn't get checked? And then it was again, and they'd never defined it. Anyway, I Googled it. It's a type of antibiotic, peptide specific, made by different bacteria. I thought that was interesting. And also a little presumptive, I must say, of the authors to assume that we all know what the heck that is without defining it. And I think they would have been just fine saying antibiotics. I think they're flexing a little bit. But anyway, so that was one thing. And then the other thing was just that and that's what a good background should do. It set up the previous evidence for this strain. So this is using the K12 Streptococcus salivarius strain as like a lozenge to prevent streptococcal, so strep throat, and uh, viral pharyngotonsillitis in kids. And yeah, I think that's all that I have to say about the intro. I'm ready to jump in now.
All right, cool. So yeah, like you said, it looked like it was the K12 probiotic strain, and it looks like it was actually formulated in Europe, and it looks like there's some stringent guidelines with which that they actually have to adhere to as it pertains to Italian law. And apparently, this supplement needed excuse me, could not have had less than 1 billion colony forming units of this probiotic strain.
Yeah, so it's K12 Bliss technology. So I think so. I actually have a probiotic lozenge I use just for like dental health, and I checked it out, and it does actually have this strain. So it looks like you can get it in the U.S. And yeah, so it looks like for this study, 1 billion CFU is the dose that they used.
Okay. And they also said it was a multi-center, open, non-randomized, controlled clinical trial. So, I mean, kind of off the bat, we've got some bias right there.
Yeah.
It's open labeled, meaning the providers or the people who are involved in the study know what they're getting, and the participants know what they're getting. It was non-randomized, so that always can cause issues because you're not essentially equating for sort of prognosticating factors.
So
And
yeah, go ahead.
go ahead. No, go
Oh,
ahead.
I was going to say, yeah, it sounded great until we started reading the methods. Yeah.
Right. Yeah. There you go.
So yeah, so right off the bat, so open, so not blinded and not randomized, which I thought was kind of interesting.
And it was done in 61 pediatric individuals, so a pretty small trial. And they said it was multi-center. Sometimes I feel like people will say multi-center, but really it's just like two clinic locations. Was this truly like multi-center of like several pediatric clinics spread across the Milan, metropolitan area, or was this really just two clinics?
That's a good question. I don't think they actually define how many clinics they had.
Okay.
That's a good question. Yeah.
And there were, of those pediatric patients, there were 32 boys and 29 girls. Um,
Yeah, I think that's it. Let's jump into inclusion criteria. It'll tell us more about the population.
yeah, so everyone who was enrolled had to be between the ages of 3 to 13 years of age. And they had to have no less than 3 episodes in the same quarter as that of the study of the previous year.
Yeah, so a little oddly worded, but basically these are kiddos that get recurrent pharyngotonsillitis, and so much so that the season previous they needed to have at least three three times to be eligible. So this is a very specific population. These are kiddos that are getting this all the darn time.
And they also had to have, strep infection confirmed by a rapid swab for either group A or group B strep, and had no other sort of infectious disease at the time of diagnosis.
Yeah, so that was. I think that's fair enough. So they have a history of the stuff, but they couldn't have it coming in, which makes sense. And yeah, and they did objective lab testing, which is pretty standard. These sort of rapid swabs, and I remember those. Try giving that. So ironically, my 2-year-old handled it like a champ. I almost gagged all over the provider, and then my 6-year-old like literally ran across the room, and it was quite a challenge. But yeah, they are not fun for kids to get swabbed, or grown-ups for that matter. But yeah, but you got some objective data about was it indeed strep throat in particular. Cool. Alrighty.
And then also importantly, the exclusion criteria, who was also not allowed into the study, was basically um, anyone who just otherwise wasn't really just a typical healthy kid who gets strep infections.
Mm-hmm.
So they excluded people who had immunocompromisation kind of status, had undergone a tonsillectomy, so a removal of it or removal of the adenoids, anyone with rheumatic disorders, asthma or allergies. So really, this is just like your typical healthy kid who just gets strep throat infections.
Yeah. Any concerns with the inclusion exclusion criteria from your side?
Not really.
Yeah, me neither. I like that. I think it would be a population you would think about prophylactic stuff for. Yeah, just a little bit of a heads up, like you said, on the non-randomized and open, but the population looks legit to me. All right, onward.
All right. And then basically, they were separated into one to one. So one kiddo would get the probiotic, and then another one would just go into the control group where they didn't receive any treatment, which is kind of a bit frustrating because it doesn't look like they're even being like compared to a placebo. It looks like maybe just like a waitlisted group if they're not getting anything. And
Yeah. So like the method issues are like beginning to emerge, right? Like, so first of all, they do one to one, but they don't randomize, which is interesting.
also this is like kind of they didn't. I don't. So is this more of a, like a prevention study?
Yes.
Okay.
Yeah. Prophylaxis. Yeah. Hmm.
Okay. Because the next sentence was that the product was to be administered for 90 consecutive days,
Yes. Hmm.
and so I didn't know if this was like treatment for or for prevention. Okay, cool.
For prevention. Yeah.
Yeah.
Yeah, so no, to your point, no placebo. Basically, it's just the kiddos either get the probiotic or not. And it's apparently 1+1 enrollment. I don't know what that means. It says an enrollment key, but it doesn't, but it specifically says it's non-randomized. So I'm just very curious about why they would not randomize, but also how that allocation is actually happening. And of course, the concern with non-randomization is that they're being selected in a specific way, like, oh, you're going to get this, you're not going to get that, et cetera, and that the populations are different, like healthier in one group versus the other. So yeah, so a lot of questions there, but yeah, awesome. All right, you're doing great. Keep on going. Rock star status.
And then they let the probiotic dissolve underneath their mouth right after brushing their teeth before going to bed, and were told not to chew or swallow it whole,
Mm-hmm.
and could not drink or basically eat anything afterwards.
Yeah. So you want it. It's for the microbiome of the mouth.
Mm.
You don't. It's not like a probiotic you would take. For the gut. This is I always usually call it lozenge. I think they called it a dissolvable tab. But essentially, you want it to coat the mouth and the oral microbiome. That's what we're after. With the idea of and again, this was in the introduction, which is kind of cool. So usually you're right. I feel like there isn't a lot in the intro, but apparently there are two substances, salivarians, I don't know if I pronounced that right, that are antimicrobial that are made by this particular strain. And that's the proposed mechanism is that this probiotic will take up residence, release these antiviral lantibiotics, and that's why strep won't grow. Essentially, that's the proposed mechanism.
Great. And then basically they told them just to take the product as otherwise instructed to, but if they were to have any sort of symptoms of strep throat, to come back, and then if they had a positive test, would get a treatment of augmentin for 10 days, and then we're actually told to restart the probiotic after completing treatment until basically the end of the 90 days.
Okay, so I got a red flag here. How about you?
I thought that was kind of unusual.
Yeah, and but think too about how they came into clinic. Like, did they test everybody every month or so to see if they had strep? When did they test? Who got tested, and when did they test?
Basically, it's kind of like subjective. Like if you think your kid has strep throat, bring them
Uh
in.
huh. Yeah, and it's not blinded, right?
Yeah, and it's not blinded. So
And it's not blinded.
yeah.
Yeah. So now you've got this potential placebo effect where parents who know they're not getting anything, or parents that perhaps are getting some. Let's play this out. Let's say you know that you're not getting the probiotic, and
Yeah, you're likely to go be seen and get treatment as opposed to someone who's getting some sort of an intervention, even if that intervention actually isn't doing anything.
well, so maybe, right? But so that's one possibility. Or if you're getting the intervention, maybe you don't come in because you're like, well, I don't know. You said you're a little bit unwell, but you're taking something and it's probably covering it. I don't think you're getting infection because you're taking medicine, right? And so I'm just thinking about how this could skew the results. So if you are coming in less often because you're taking the probiotic, then you're going to undercount strep and make it look better.
Hmm.
On the flip side, if you are coming in less often because you're not getting it, then that would basically undercount those cases. So one thing that we should think about is it would be really great to see a table of the percentage of people from each group that came in for an assessment, right? If it was balanced, I would feel better about that. But then also, you're just like, well, is it, are they not coming in because of the placebo effect? Are they not coming in because it's actually working? And you can't tell that. And that's why you need a placebo. You need to blind it.
Mhm.
Or you need to be going to their door and swabbing everybody all the time, right? That's the other thing. But because the outcome, which is the number of positive swabs, depends upon the number of people that show up to get swabbed, and because that number of people that show up to get swabbed can depend upon your knowledge of whether or not you got the probiotic, it sets us up for dramatic potential bias. So that was sort of a really big red flag to me, and kind of underlines why you need placebos to begin with for this sort of business.
Yeah. So, I mean, one thing I wouldn't discredit people for would be to like just kind of stop at this point, and there's just too much risk of bias going on that really the results have to be taken.
You're already like, throw it out. Yeah.
So I'm kind of already there of like this. Let's throw this out, but we'll entertain our
It'd be
fans.
a good learning experience. So I think this was actually turned out to be a really good learning experience. So let's keep on going.
Yeah.
Alrighty. Where are we at?
I'll skip the part where they kind of defined how they diagnosed viral infection,
Okay.
and just kind of get to the objective and the results because of time.
Mm-hmm. Yep.
But basically, what they did as like their primary outcome was the efficacy of the probiotic supplement in preventing infection during the study period, as well as reducing viral infection during the same time period. They also looked at the onset of side effects
Mm-hmm.
or toxicity while the product was being administered. And then for secondary objectives, which I still thought were clinically relevant, was basically the frequency of antibiotic use, frequency or reliance on antipyretics. So basically using Tylenol to reduce the fever.
Mm-hmm.
This one is actually really important. Working days lost by parents.
Heck yeah.
So having
Mm-hmm.
to call out of work or go to work later or something like that because they have to stay home with their kid. And then absence from school for children.
Yep. So I agree. I think the outcomes were excellent. I think the way they defined the infections were good. Perfect. Okay, great. And then I don't think there's anything we really need to cover in the statistical analysis. The only thing I would add from a methods perspective, I did not see any mention of a registration of a protocol.
Yeah, I didn't see that either.
So that's going to be another red flag, right? Because people can always tweak how they decide to analyze stuff after the fact. Look, the thing is, we don't do this for money. This is pro bono. And quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential. And there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. Okay, so that's all of our method stuff. Let's jump into the results.
Right. Okay. So when we look at table, I think it was, table 1, looking at the baseline characteristics, there were no statistically significant differences between the two groups, but they didn't really look at many different characteristics.
Yeah.
Both groups had 30 participants. The group that received the probiotic had 19 males versus 13. Age was essentially the same between the two groups. And then the episodes of pharyngotonsillar infection was similar between the two groups, with both groups having about 3 per quarter.
Yeah, in the previous year. So this is the type of table you would look at to see if randomization worked. Of course, they didn't randomize. So their counter argument could be, yeah, we didn't randomize, but these groups look the same. But to your point, they only really report on three variables: sex, age, and previous episodes per cycle. The only one that I would, well, I mean, I guess theoretically sex and age can be predictive, but episodes per child would probably be important. But yeah, there weren't a lot of variables here, and so again, we don't know if these groups are equally balanced. And the fear, of course, is without randomization, they may not be. All right, keep on going.
And also, a kind of another reason why it's important to have a trial registry is because in that registry they could have outlined, what those baseline characteristics were going to be, and so they may have had more and just decided not to report on them.
Yeah, exactly right, exactly right. And we have no idea because they didn't register their protocol. Exactly right. Okay, cool. What else? Anything else? Da, 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 da. All right, keep on going. What's the next thing that comes to mind?
I'm trying to look at table 3 and make sense of that, just because that's the next one up.
Yeah. So, okay. So, for sake of time, let me jump in here and kind of go through the results, and then we can talk about it. So they let's so okay. So let's look at table 2 first. So table 2 is going to be, it reports the number of treated, infections the previous year, which is about 90 for both. And then it talks about the year with the preventative probiotic. And so you have 90 basic infections, treated infections the previous year. But in this year, when you take the probiotic, if you take the probiotic, only 3 people, whereas last time it was 90, only 3 of them got treated for an infection, whereas 84 in the untreated group got treated, very similar to that 90. So you have this dramatic reduction. So very little change if you for the untreated group from one year to another, which would make sense. And you have this dramatic reduction, a 96.79% reduction in treated infections in the treated group. So that looks like a dramatic effect size of a very, very effective intervention.
But
Um, but yeah, go ahead.
but we have it kind of circles back to what we were talking about before, with why we're concerned about not having a placebo.
Yeah, exactly. Right. So when I actually, and I know you like to not read the abstract on purpose, which I think is smart. I read the abstract first on this one, and the first thing that put up a red flag for me actually was the effect size.
Yeah,
It was way too good.
yeah.
It was way too good, and I was looking for issues from the get go because of that. And I mean, 97% reduction, really? I mean, maybe, but really? And then you have all these methodological issues, and you're like, huh. And then
Mm.
table 3, just for sake of time, this is the viral pharyngotonsillitis. And we see a similar story in the previous year. About 25 people in both groups had viral infections. And then in the year where there was treated, the people that didn't get treated, just about the same number, 24 as opposed to 28. But if you got the probiotic, only 5 people got viral infections compared to 25 the year before. So again, another dramatic improvement, in 80% reduction. Very, very good. Is it too good to be true? Is the question.
Well, the answer is yes.
Dun, dun, dun. All right. So let's kind of close up here. There are a few other things I wanted to touch on, and then let's chat a bit. So we talked about the actual effect. Um, and then here's some lines that were just more red flags for me. So for the listener, as a learning example, first thing that was a red flag to me was reading the abstract and seeing the effect size just looked too good to be true. You could tell from Adam that there were red flags with non-randomization, no placebo group. And then we had this sort of interesting enrollment piece, et cetera, et cetera. We didn't have a registry. So all of these sort of red flags. Here was another red flag for me. Here's a line. The treatment, let's see, it was well tolerated and without any side effects worth mentioning. That's just the strangest.
It's just perfect. It's the perfect treatment. It cures everything, Josh.
Cures everything, but no side effects worth mentioning. Don't you think that's kind of an interesting language? Like, it didn't sound very much like a regular paper to me. And I was also like, well, who decides what's worth mentioning? Is that defined a priori? We don't have a registry. So that was already kind of a red flag. Compliance was very good. Da 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 da. What else? And then they go through and they talk about the benefits from a loss of school and a loss of work perspective, which obviously makes a lot of sense. It's going to be dramatic because you have so many fewer infections. There is less days lost of work. One other cool thing they did, and again, just going fast here, skipping over some details, is they looked at like a financial analysis, like how much it costs to take the probiotic for everybody for 3 months, and then how much was spent on antibiotics and on antipyretics, et cetera. And it turned out overall, when you do that, it's obviously more expensive to take the probiotic. But then they say about, well, yeah, but it saved this many school days and this many work days, and it's really just like was it 30 cents a day to prevent it? Sort of this interesting kind of calculation about the benefit. So they do some financial analysis there as well, sort of back of napkin analysis too. So we don't have to then go through the discussion, and it's just sort of more and more waxing poetic about how amazing it is. I have a note here on the side, reads like an infomercial. Oh, here we go. Here's a great one. As each family spent 30 euros more than those who did not resort to the K12 strain, it can be stated that each saved day of work cost about €2 per family. Hiring a babysitter to avoid losing a working day will certainly cost much more than that. It was just like, it just did not sound like a proper research paper. Maybe English wasn't their first language and these are translation things, but it just, again, lots of red flags. It read to me like a infomercial. Now, with everything we've said, what's your guess about the affiliation of the authors?
Well, I actually I just looked at that and I was going to say that big probiotic was involved in this. And the lead author is the main formulator of the tested product and involved in the scientific council of the company that tested the product. So this has
No, even worse. It's trading the tested product, aka the sellers of the product. He's on the scientific council of the company that owns it.
This just has the red flags all over it.
Yeah. Yeah, it does and does. And so this is a classic example. I'm going to use this as a teaching example from now on. This is a classic example of like I don't know. I need to come up with a good phrase. It's like when industry
not trying.
Yeah, it's like industry wants to say that there's like research behind their product and it's peer reviewed and all that, and then it's basically an infomercial for the product. And I just feel like it's science washing.
Yeah.
It's like science washing, essentially, or peer review washing or something. So yeah, there's a classic example of industry funded research. Now, that of course does not mean that this stuff does not work. I would be willing to bet that in real life it doesn't work as well as advertised, but the mechanism makes sense. It may work very well. This is a massive effect size. So even with all this bias, it could be that there is a very reasonable beneficial effect. All of this to say we have no idea if that's true or not because of the methods. And that's why methods are important. And that's why we have to be cautious when if I don't know where my patient found this. Probably, well, I don't know. I'll have to ask her. But a lot of these companies, I just went the other day to recommend a supplement and went to the website and they're like, science, click here. And of course, click there, clickbait for Josh. And it like lists all these peer reviewed studies. And like, ooh, there's some studies behind this. But, you always have to ask, which studies are they going to list on their website and who funded those studies? Anyway, so I thought it was a good teaching example.
Do you think that industry should start using like reverse psychology and it'd be like our results are meh at best? Have that as the advertisement.
Yeah. No, I mean it's so so I talked a lot about this. I gave this talk at CRN about this too. It's like if industry, so let's assume the best about industry, just for sake of argument. Let's steelman them, right? So it's like you believe in your product. You want to show that in a rigorous way. A lot of scientists involved in these supplement companies, and so you want to do research and show the world that your stuff works as well as you know it works. And so the question is, how do you do that in a way where we're not laughing about it later, like we are right now, right? We're not like, oh man, we can't believe a word of this. Is there a way to do that? And There were a few recommendations that I had in the talk. I'm curious what your thoughts are. One, of course, is just to write a check and walk away. And you see that in the big New England Journal of Medicine studies, like on the drug manufacturers. And the other is to have at least have a registry. I think that saves so much of these issues, right? To have an a priori protocol with reasonable outcomes, and then published ahead of time, and then we can all compare it. And a lot of this p hacking, a lot of the outcome manipulation that we see, I think is gonna show up. And the journals have to stop publishing papers that don't have protocols at all, let alone a priori protocols. I don't know how this is still a thing.
I prefer the cut the check and walk away with the caveat that they're publishing results no matter what and not getting their hands like all up in the manuscript.
Yes.
My concern with the former option is that oftentimes you'll see like protocol deviations and then them justifying why they did a protocol deviation. So it's like, oh yeah, we did do a protocol registry, but because of XYZ, we actually had to do this other thing instead. And so then it kind of does become a little bit murky, especially if you see it happening a lot. So I would rather just a company be like, yeah, we just donated $400 million to this project,
Yeah.
and then we just walked away, and whatever it is, it is.
So I used to feel that way, and I still feel mostly that way. Some people came up to me after that conference I was talking about, who were in industry. They're industry scientists, and they were like, they told this story about how they had done that, written it. They really believed in their product. They wrote a check and walked away. They gave it to reputable scientists, and when they saw the paper the same time everyone else did, they were appalled because, according to this person who was talking to me, the methods just stunk,
Mm.
and it made zero sense based on the mechanism of how they thought this thing worked, and they're very, very frustrated, and the result was negative. And so I can see an argument where, like, if you know your product really, really well, like, you should at least have a voice at the table in methods development. Maybe not a voting voice, but at least being able to say, like, hey, here's our chief scientist, they know this product better than anyone else in the world. Like, let's at least let them have a presentation about why they think this method is a bad idea, etc. So yeah, anyway, I think that made sense to me when I heard that story, and I could totally see that happening. We see that in integrative medicine, where non-integrative researchers design these studies that make like zero external validity sense.
Yeah. I mean, I think what they could do then is just like hire on, or not necessarily hire, but like consult an independent methodologist who can. So, you know how like sometimes in meta analyses, they'll have, like two reviewers and a third for any sort of disagreement.
Yeah.
You could kind of do the same thing from a method standpoint of like have two methodologists and a third independent to resolve any sort of differences, where
Oh,
one could be the methodologist from the research team, one could be from industry, and then one who's not related to either.
that's an interesting idea. Have the methods be independently drafted? That's cool. I've never heard of that, and I've never thought about that, but I think that's really interesting. Huh. Because yeah, if you have independent methodologists and they come up with totally different ways of analyzing it. Yeah, no, that's very cool. Neat idea. And just more ways of, yeah.
And not even necessarily coming up with something different, but being like, yeah, no, the industry methodologist recommendations make more sense because of these reasons,
Oh, I see what you're saying.
or no, we can't do that.
I see.
Yeah, so they don't necessarily have to make new methods, but kind of serve as an arbiter, if you will.
Oh, that's a neat idea. Okay, so basically, you have an independent panel design the study. Then you have the industry group saying this is a terrible idea and this is why. But then instead of the other group getting defensive and saying, well, they're just saying that because they want it to look good, you have a independent person looking at it and saying, no, industry's right about this. That is really cool. That's even cooler than what I thought you were proposing. Neat. And more realistic too. I don't know why that's not done. Maybe that is done, and I just have never heard about it.
And you could even like blind them to it. So this way you could sort of blind the authors on the paper, and you could blind where the funding is coming from. So this way they don't know,
Yeah,
and there's no influence.
I love that. Really, really love that. Cool, man. Well, great. I think we got through it in time with some time to spare. Thank you, dear listeners, for listening. Thank you, dear patient, for recommending the paper. I thought it was a really good learning example for all of us. And I think it worked out really well, Adam, that you didn't read ahead of time, because I think it was really cool for the audience to see, and I could see in your eyes, and then the audience could hear in your voice, like as the red flags were accumulating. And then by the end, you were like, oh yeah, I am not surprised at all what the affiliation here is with the authorship. And I think that is exactly, my thesis on how people should read papers is like, look for those red flags, and just, it doesn't mean it's bad. It just means look deeper. Wait a second, something's off here. And you could tell, you're like, wait, that doesn't smell right. And then it would just kind of build and build and build and build. So that was awesome. Well done.
Josh, are you someone who sits through a movie no matter like how bad it is, or do you have the wherewithal to just stop it and be like, this is terrible?
Oh, I definitely stop. Yeah, I do have to finish books, and I have to finish podcasts. That is a problem. That's wasted a huge amount of time in my life, years, and I cannot move on until it's checked off the list. But for some reason, movies, I don't have that problem. How about you?
I can stop all three of them and just move on with my life. And I think that people, when they read papers, need to do the same thing of like, no,
yeah,
these are awful methods. I'm done.
Yeah, you said that 2 lines into the method section. I think that was when you made that, like, oh, we could just stop here. We can't believe a word that comes next. And yeah, fair enough. And you were right. So awesome, man. Well, thank you for another great pod. And dear listeners, thank you for listening. Oh, one thing I've been wanting to say that we haven't said yet is so we have a lot of institutions that are members of Dr. Jerome Club. So if you are part of a university, faculty, students, et cetera, or even large clinics, reach out to them and ask them about, we call it institution level subscriptions to Dr. Jerome Club. Lots of universities and state associations, naturopathic state associations, chiropractic associations are members, and that basically provides free access to all of their membership. So if you are a member of a university or an institution or a clinic, and you don't feel like you can subscribe as an individual, remember that institutional subscription is an option as well. That is my disclosure and connection. I am owner of Dr. Jerome Club, so I want to be transparent about that. But also, it's an awesome product, and you should come and listen. All righty. Take care, everybody, and we'll see you next time. If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.